As always, it's a pleasure to talk to this crowd, and I'll try to get through this as quickly as I can, although the time is short. There's a fair amount to cover. Welcome questions at the end. I have no conflict of interest to declare. And the objectives of the talk today, I'm not going to focus much on therapeutic issues, but talk about diagnostic methodologies. And as Dr. Rickade mentioned the other day, we wanted to sort of champion a shift of conceptual focus toward thinking about hindbrain herniation because of the confusion of this Chiari I terminology, which I'll get into a little bit as we evolve through some of these concepts. I'd like to summarize pathophysiologic mechanisms underlying hindbrain herniation, some of which has already been covered with respect to hydrocephalus and pseudotumor, and some of the other speakers as well. I'd like to suggest some algorithms for exploring these potential mechanisms in clinical examination and testing, and support the development of treatment objectives recognizing and addressing these kinds of principles. So this is a common medical model of understanding what's going on, treating the specific aspects of it, and looking at specific and watching outcomes based on management of pathophysiologic mechanisms. Just some definition of terms. Diagnostic methodology is a system of methods used in clinical problem solving, so that's what we're talking about, how to solve this clinical problem from this standpoint, really the identification of and diagnosis of Chiari I malformation. And algorithms is sort of a little bit borrowed from the computer age jargon of today and references lists, processes, or sets of steps which can be followed to help define these problem-solving methods. If any of you are fans of Outwal Gawande, who's a surgeon, talked about making of lists and how this can be so helpful, and all of us have our to-do lists well ensconced in all of our personal assistants. I bet you thought that the patient was the only one with a problem here today. In order to help solve that problem, your physicians have to have a clear conceptualization of what that problem is. Either through education or experience, they have to have seen it before. We are, for the most part, capable of seeing only what we're looking for, and that is no more true than in the diagnosis of Chiari malformation. So this is where the physician has a problem, because patients don't come with labels on them. And the diagnostic challenge is identifying what's in the background of the many systematic complaints that patients have. The patient's problem can be specifically looked at in the confusion that all of you have all too personally experienced in your personal lives and you're dealing with this disorder. Most patients have been evaluated by 5 or 6 physicians, one of which is bound to have been a psychiatrist, and without a clear diagnosis having been found. More often, women or girls are affected, at least in the 3-to-1, and we know the prejudice is involved in the physician-patient relationships in that regard. The age of onset is quite variable, both from young adults to aged patients. The oldest patient I think we've operated on at the Chiari Institute was 86 years old. Symptom onset may be sudden, and it may be very chronic. And there are also often multiple symptoms, which is frequently confounding. The underlying condition is often also relatively rare. As we get better able to diagnose it, we have seen over the course probably of the last 10 years that it's probably more common than we used to think it was. But still, in textbooks and in the conceptualization of this in both neurologists and not so much neurosurgeons, but the general medical community, is the thought that this is an unusual thing. The average neurologist probably figures they see about maybe with Chiari malformation in their entire practice career. Most neurosurgeons, without extensive experience with Chiari, probably operate on 2 or 3 patients a year. So it is kind of rare. What's the physician problem? Well, physicians must have at some point been taught the common presentations of the problem so that they have a gestalt or a feeling for the disorder. And we must understand how the component symptoms are linked together so that if they see fragments of the presentation, they can kind of put it together and look to put the puzzle together. The possibility of the disorder occurring must at least come to mind so that the process of differential diagnosis can be applied, not without which neither the physician or the patient is getting anywhere. It's a classical problem of the Indians, or blind men and the elephant. And frequently patients have many of the following diagnoses. And as so depicted in the diagram here, you can see what that problem entails. What are the barriers to apply some of these diagnostic methodologies? Well, diagnose because it can present very insidiously and very suddenly, so it's a little bit confounding in terms of what's the usual presentation. There often isn't any usual presentation for Chiari. And not infrequently, maybe 25% of the time, it can be precipitated by traumatic events. And that brings up medical legal issues, which also confound the questions of secondary gain and patient and physician involvement. The multi-symptomatic nature of Chiari involves pain and fatigue as frequent components, and these are all too frequently confused with psychiatric issues, and you've had that addressed by several of the speakers today. Physicians, as they learn about disorders in their early training, they learn about the worst case presentations. What's in the textbooks, at least in the neurology textbooks about Chiari, is that it presents with a cape-like dissociated sensory loss, downbeat nystagmus, and a cough headache. All of these are very rarely seen, as well as ataxia, which was talked about a bit. The patients we see nowadays, probably 95% or better, have perfectly normal neurological exam. Makes it a little bit boring for me, but it's still part of the job. There are other compensations. This clinical approach to it, because patients don't have much to show for their disability, although this certainly is a real aspect of the condition. Probably, the most common and often only physical finding is unsteadiness in tandem standing. And the issue of cough headache, although is a classical discussion, a suggestion about the diagnostic or a symptomatic feature. More patients, and particularly children, will have headache with laughing, crying, or other activities, but not necessarily so much with particularly cough headache. In the medical community, disorders rise in awareness to the extent that there are treatments available, and they're often driven by pharmaceuticals. We, in addition to some of the folks in the ASAP administration, have been trying for 3 or 4 years to get on the program of the American Academy of Neurology, unsuccessfully in their educational program, to talk about Chiari. There's plenty of discussion about headache, but it's all directed to through the pharmaceutical industry at the management of migraine. Now, migraine is very, very common, and much of the discussion about it is well placed, but somewhat to the exclusion of other secondary kinds of headaches, certainly among which is Chiari malformation. Education is a slow process, and I know patients have trouble coping with this issue because traditional texts are about 10 years behind the times. Most of what passes in subspecialty focused communities in groups like this helps put this forward on a year-to-year basis. But most of the written material out there and what's been taught to the medical professionals who've been out of training for 4 or 5 years is basically kind of ancient. And that's reflected in some of the opinions of neurologists that feel that Chiari malformations are really asymptomatic, incidental findings, and are frequently not the cause of any of the dismay that patients feel. And I can't tell you how frequently that's the case as patients present, and I'm sure many of you have had similar experiences. The diagnostic tests and the definitions, as you've heard already, are a little bit fuzzy and are still evolving. So that adds to the complexity a bit, certainly. Well, what's the solution? Well, patient education, certainly. That's part of what we're doing here. And I'm not sure any of you are familiar with the Cy Sims establishment in New York, but he was a clothier that had chutzpah to say that an educated consumer is our best customer. And that's sort of what we're here today. And patient service organizations like Chiari and others related to Chiari, as well as HIV organizations and other disease-specific patient-driven groups have been really instrumental over the last 15 years in driving recognition, management, and cost allocations, even at a national level. From a historical perspective, our knowledge and understanding is clearly improving, and I hope you can appreciate that. I certainly can after seeing and participating in these groups for the last 10 or 15 years. In talking about the evolution of some of the diagnostic methodologies, I thought I would take kind of historical perspective. Back 40 or 50 years ago, Chiari was by and large oftentimes recognized at autopsy, and sometimes led to the notion that this might have been an incidental finding. But there was very little known about the specifics of the disorder. Through in the last 15 years, or 20 years or more, there really has been an accumulation of studies, some of which put through by Dr. Nishikawa, who worked with us at the Chiari Institute for a while, to try to understand what were the morphologic abnormalities in the posterior fossa and what were the underpinnings for the tonsillar descent. This resulted in some relatively primitive morphometric analysis, and this has continued to progress in our hands and other folks' hands to try to have better techniques to identify what the structural abnormalities underlying Chiari. In 1999, Dr. Miller had put together this paper on redefining the Chiari I malformation to really bring home the fact that this wasn't just a cough headache kind of syndrome with ataxia and funny eye movements. It really was a broad spectrum, with a wide variety of clinical features that were identified in a number of different areas. Certainly the suboccipital headache was predominant, but there were ocular disturbances, acoustic and vestibular complaints, dysesthesias, chronic fatigue, bulbar and coordinative problems, as we've heard speakers talk about, concentration and memory difficulties, neck and shoulder, cervical pain, low back pain, as well as even urinary symptoms. It sort of helped to redefine this whole area and help to focus people a little bit on the diagnostic issues involved in identifying patients with this syndrome. And this was also evolving right along and adjacent to the evolution of MRI technology through the 90s and into the new millennium, as MRI technology became increasingly available, cheaper, and more widely used. In the early part of 2002 to 2004, Dr. Miller and our group looked at 380 cases to look at why, one of our interests was why do Chiari surgeries sometimes fail? And we were able to identify a number of issues, persistence of or enlargement of the syrinx, possibly suggesting that maybe some decompressions might be inadequate. So maybe there was some thought needed to what's the appropriate kind of surgical approach. Meningomyelocele were frequently observed and related to either the material used in the duroplasty or possibly leakage, and later became apparent that chronically raised intracranial pressure issues might be at base some of the things to be concerned about. So our concern about what was going on with intracranial pressure chronically in these patients became of interest. Also, it was clear that C1 laminectomy, as part of the procedure, would occasionally destabilize the cranial-cervical junction, and there was some issues of instability. And Dr. Bolognese, I credit really with the insight in about 2004, 2005, with identifying a cadre of our patients who had Ehlers-Danlos syndrome. And some of the rehab folks and as well as the pediatricians talked about this issue of hypermobility syndromes and how important this began to be in terms of identifying this, which was in my other life as a neuromuscular physician, I really hadn't given too much concern, but as I educated began to pull more and more people out of neuromuscular clinics because they were just hypermobile individuals who couldn't function. They didn't have muscle disease, they really had joint disease. And we came across cases of unrecognized or previously untreated hydrocephalus. So we really felt that we had a lot of work cut out for ourselves. But circa 2007, the definition of Chiari malformation was still pretty much limited to what Dr. Rickate mentioned as this totally arbitrary kind of 5 millimeter or greater tonsillar descent limit. But this practice really did not emphasize other etiologic factors. So what started to evolve in terms of trying to understand is we needed to develop some kind of a gestalt for what these patients would be like. And as part of some of this effort, we looked at about 900 or so patients and developed this decreasing symptomatic list. These symptoms were present in more than 50% of patients, and certainly the most common was occipital headache, almost daily, neck pain and stiffness radiating to the shoulders, frequent tingling, numbness, dizziness, unsteadiness, so many of the things that other speakers have talked about, and you're pretty familiar with, chronic fatigue, and a varied list of constitutional symptoms, including blurred vision, ringing in the ears, urinary urgency, palpitations. To really understand what's going on, physicians need a way to kind of comprehend and link together what's the commonality in this. And when we really look at this area here, which we're concerned about, where there is tonsillar descent, and pressure is exerted here at the cranial-cervical junction, not really on the tonsillar structures, which we have recognized empirically over the years that we can sacrifice surgically and have really no impact on the patient's function. But this area here is where so many of the vegetative functions, as neurologists refer to them, regulation of sleep and wake cycles, regulation of blood pressure, thermal regulation, heart rate regulation, gastrointestinal function. And if you think about the symptom complex in these cases and understand this is the link, the posterior fossa, what we might maybe call posterior fossa syndrome or whatever, is linked to really this localized brainstem dysfunction. And that kind of pulls together this very divergent sort of list, because all of these relate to primitive kind of homeopathic and vegetative sort of functions underlying nervous system. So being in the habit of looking at lists and trying to grade, at the Chiari Institute, we developed a way to kind of use an old scheme of functional assessment. We did various pain assessments and began to really bring out some of the morphometric measurements to see how this would help us in categorizing patients. We Cine flow studies, which you can see the evidence of blocked or reduced flow posteriorly, began to be used more widely as a way to look at CSF dynamics. And in other CT studies, we can look at certain aspects of previous posterior fossa decompression, C1 laminectomy, the structure of the upper cervical vertebrae, presence of sometimes very elongated styloid processes, and other elements that might be helpful in trying to identify particular aspects different from patient to patient that might have implication not only in a diagnosis of the type of hindbrain herniation, but in the management and treatment of it. This is a patient of ours who demonstrates a lot of the features of Ehlers-Danlos syndrome. And you can see the flexion at the wrist. These are part of the Baton scoring system that can be helpful in identifying these patients. This hypermobility, hyperextension, this is another category of the Baton scoring. She has the ability to dislocate her shoulders at will, do this backward handshake maneuver. She's able to dislocate her shoulders, which is not advisable to do, but unfortunately, patients are more than willing to tell you how that they can do all these things. She can dislocate her hip at will. And these are parlor tricks that that unless you ask about, a lot of families won't tell you about. She has skin laxity at the knees, and she has hypermobile patellae. And she's able to do this other ballerina-type maneuver. So in looking at some of these patients, we developed kind of algorithmic approaches to screening patients for this with good family history, particularly attentive to, in this group of patients, to trauma history, as well as to a history of trauma in general, because some patients with just trauma alone and not hypermobility will display some of the craniocervical instability issues that patients with hypermobility do. We bait and score patients, and we look for other physical signs of these conditions, such as the elasticity, the presence of skin stria, different types of scar formation, and poor wound healing. Arm span is helpful in segregating a subtype of Marfan syndrome, looking at other testing for hypermobility, tender points, and TMJ screening for fibromyalgia-like conditions. An axial loading maneuver where we put some weight just vertically down on the head. Many patients are very sensitive to this and are relieved by cervical extraction. We can look at that in other morphometric tests I get to in a minute. We screen patients with electrocardiograms to rule out mitral valve prolapse and aortic root dilatation, which can occur with this, and abdominal ultrasound for abdominal aortic aneurysms in a very rare subset of patients. We also can use some morphometric and radiographic features such as a clival axis angle. This kind of shows the instability at the craniocervical junction, the Grab-Oakes line for basilar impression, and stand-up MRI techniques, which I'll show you in a minute, which can help on identify this mobility. And invasive cervical traction, where we can actually put some numbers to the gravitational effects here. Here's a patient with connective tissue disorder in supine and sitting position. You can see that there's tonsillar descent that increases. There's an increase in the angle of the clivus to the odontoid process, and somewhat of a collapse in the distance between the basion and the dens. This is another demonstration of that and the reversibility of this with cervical extraction. This typifies the sort of mechanical activities that can go on a day-to-day basis and underlie the symptoms of neck and cervical pain. This was put together in a publication. We became interested also in complications of prior surgery where patients developed cerebellar slumping. And you could see that following posterior fossa decompression, instead of the cerebellum reshaping itself and that the brainstem seems to have been elongated and pulled down into the cervical region. And also you see the basilar impression of the odontoid here is increased, suggesting that there's some craniocervical instability following laminectomy. So this became an important aspect of screening patients. Another clinical interest was observations in key case studies of patients. This is a 20-year-old man with tethered cord syndrome and Syringomyelia. Before section of the filum terminale, you see the syrinx, tonsillar descent, and 15 years after SFT, he's got quite a bit better anatomy, and the syrinx has remained collapsed. This is a 27-year-old male with MR imaging before and 8 months after section of the filum terminale, having already had a posterior fossa decompression. You can see the cerebellar slumping in a pull-down sort of effect that is relieved by release of the tethering. And lastly, 18-year-old young girl with who had MR imaging before and 3 months after section of the filum terminale, where you see this tonsillar elevation and change in the basilar anatomy. This lastly is an 8-year-old child who had elevation again of the tonsils following section of the filum terminale and collapse of a moderately severe cervical syrinx. And in the thoracic area, similarly, with the terminal syrinx in the absence of cervical syrinx, collapse of this type of syrinx without in, intervention in the syrinx itself with shunting. We also made some observations about the formation of the foramen magnum in patients with tethered cord syndrome and Chiari malformation type 2 shared the presence of a relatively enlarged foramen magnum, which could be looked at morphometrically, and was discussed in this paper, which appeared in 2009. Continuing to pursue our penchant for lists and documentation of things, we were in a habit of using tools such as this to screen patients for symptoms of tethered cord syndrome and to look at stimulation tests such as heel walking, pelvic traction, truncal flexion and extension, and documenting the presence of other aspects of this that might be helpful, which are typified here. In the clinical picture, look for typical tethered cord-like syndrome with pain in the back, pain in the legs, sometimes very nonspecific, numbness, tingling, and other things. Phylum terminale traction tests, where we try to stretch the spine in such a way that we may aggravate some of these symptoms. Urodynamic testing, and a lot of other morphometric features localizing the position of the conus, using a prone image to see if the tip of the conus remains suspended in a prone position. In other words, it doesn't flop back and forth when you change positions. Presence of cerebellar prolapse after decompression for Chiari. Isolated thoracic Syringomyelia, the presence of scoliosis, spina bifida occulta, and other segmentation abnormalities. Almost finished. Lastly, although not such a great experience in our particular institution, but in other places, Dr. Shivink in Cedars-Sinai in LA has had a good experience with patients with CSF leaks, demonstrating headache-like syndrome with very positional features and these diverticulum and CSF leakage here out from the dural sheaths, leading to a low-pressure syndrome. So when we look at our patients with this kind of medical approach, we, in some studies that were done a while ago, identified patients with borderline Chiari less than 3% of the time, patients with symptomatic but not very severe Chiari malformations 40% of the time, and about 60% of the time patients with Chiari with functional scores indicating a relatively severe degree of disability in about less than 60% of the patients. So these evaluations included symptom questionnaires, screening for hereditary disorders of connective tissue and tethered cord, and looking very particularly for both increased and reduced intracranial pressure problems and pain assessment. Of the testing done following medical examination, and that the MRIs with stand-up MRIs if indicated, and contrast studies in the case of a syrinx, cine flow studies and 3D CT imaging in appropriate circumstance, although we're concerned about the radiation exposure in this group of patients. A simple CT can amount to a 250 to 300 chest x-rays in terms of radiation exposure. Morphometric measurements in cervical and lumbosacral spine series, and particularly scoliosis series, where patients with mild degrees of scoliosis really don't become apparent. So we've tried to look and really come down to assessing the cranial-cervical junction with sort of a mechanistic way to look at the major effects physiologically that can occur, such as the squeeze-down effect, which is the traditional Chiari, shakedown, which is the patients with connective tissue disorder, pull-down in the case of tethering of the cord from below, intracranial hypertension or a push-down mechanism from hydrocephalus, arachnoid cysts, tumors, and the like, which are particularly rare, and rarer still cases of intraspinal hypotension and CSF leakage. Thanks.